Welcome to the HIV and AIDS Care Series. This is broken up into 4 sections, and this is Series 2, the diagnosis code. The next 2 slides are the next slide is a disclaimer, and the next slide just focuses on the learning objectives. The first objective for this series is to identify and explain the difference between the ICD-9-CM and the ICD-10-CM codes, to explain the diagnosis code selection process, to explain the importance of proper code sequencing, to identify the various ICD-9 codes for symptomatic HIV and AIDS, asymptomatic HIV, HIV-2, and inconclusive HIV, and also to explain the differences between all of the different conditions. The acronyms used in this presentation are shown here on this slide. Here are some additional acronyms that are used in the presentation. So let's begin our discussion about the ICD-9 coding system. The acronym ICD-9-CM stands for International Classification of Diseases, 9th Revision, Clinical Modification. The ICD-9 codes was developed by the World Health Organization in 1948. It was revised and published for use in 1979 in the United States. CMS, the Centers for Medicare and Medicaid Services, mandated the use of the ICD-9 codes on all health claims since October 1988. So basically what that means is claim submission requires the use of ICD-9 codes in order to be considered for reimbursement. CMS revised these mandates to reflect mandatory correct reporting of ICD-9 codes. In 1988, when CMS initially mandated the use of ICD-9 codes, it was not necessary to report the correct code. But when they revised the legislation, it became necessary to report the correct codes to the highest level of specificity. And we'll look at a level of specificity and coding when we get to the coding slides. For the purposes of ICD-9, the ICD-9 codes are used to describe medical conditions, diseases, injuries, and poisoning. The ICD-9 codes are updated annually. The codes are reported on all claim types: physician claims, institutional claims, pharmacy claims, DME claims, etc. So any claim that is submitted to Medicaid requires the use of an ICD-9 code to establish the patient's medical condition. We covered modifiers in Series 1 and 1A, so it's just important to mention that modifiers are never reported on ICD-9 codes. There is also a list of supplementary classification codes in the ICD-9 code system that describe medical care rendered to patients whom are not sick but require medical attention, such as the well visits. Also, the ICD-9 codes describe how injuries occur and how poisons occur. They also describe where injuries occur and where poisons occur, and misadventure during surgery. So, for example, an ICD-9 code that describes misadventure during surgery, the removal of a left leg when the documentation states the removal should have been of the right leg. Just an example of the supplementary classification codes. The ICD-9 code system will be phased out on October 1st, 2014, and will be replaced with 2 new coding systems, the ICD-10-CM and the ICD-10-PCS. ICD-10-CM stands for International Classification of Diseases, 10th Revision, Clinical Modification,
And the ICD-10 PCS system stands for ICD-10 International Classification of Diseases 10th Edition Procedure Code System. The ICD-9 code system has been in existence since 1966, and the code set is currently outdated and it does not reflect emerging technology. The ICD-10 coding system is consistent with all of those changes in healthcare, and it provides a more advanced level of coding that reflects emerging technology. ICD-10 codes, the ICD-10 CM codes are used to report medical conditions. The ICD-10 PCS codes are reported on inpatient hospital institutional claims only to reflect the facility bill. So in this setting, where you will be performing and rendering HIV and AIDS care, you will never utilize the ICD-10 PCS code system. You will only utilize the ICD-10 CM codes along with your CPT codes, which was covered in Series 1, and your, the CPT codes was covered in Series 1 and 1A. The E&M codes was Series 1, and the pathology and laboratory codes was 1A. So to continue the discussion of the phase-out, in addition to the ICD-10 CM codes when they are implemented on October the 1st, 2014, you will continue reporting CPT and HCPCS codes along with the ICD-10 CM codes. Some additional information regarding the discontinuation of the ICD-9 code system. For now, we will continue using the ICD-9 CM codes through September 30th of next year, 2013. So any claims submitted with ICD-10 codes through September 30th, 2013 will be denied by your Medicaid state agency. After October 1st, 2013, I apologize. This slide has an error on it. As we stated here on the first slide, the phase out is scheduled for October 1st, 2014. So this slide should say 2014. It should say 2014 here, as well as here and here. So the phase out is October the 1st, 2014 for the ICD-9 code system. So any claims that are submitted through September 30th, 2014 are appropriate with the ICD-9 CM codes. On October the 1st, 2014, you should begin utilizing the ICD-10 CM codes. Check with each individual state Medicaid agency because some agencies may still continue to use the ICD-9 code system. So it varies from state to state. So here is a slide that provides an overview of the commonly used ICD-9 codes that will be reported when performing any HIV and AIDS care. V0179 is the code that is used to report exposure to HIV or AIDS or pre-exposure prophylaxis. V67.9 is follow-up exam. V69.2 is high-risk sexual behavior. V69.8 is other problems related to lifestyle. This code can also be used for asymptomatic high risk, and it is important to note that this code is only reported as an additional code to, for example, exposure, or for a patient that is diagnosed as HIV positive, or for a patient that has the HIV infection. So this code is never reported as the principal diagnosis. It's only reported as the secondary diagnosis when applicable. Another commonly used code would be V70, routine general medical exam, also known as the well visit or the annual visit. V73.89 is special screening. So this is the code that would be utilized for patients that are actually having the HIV screening test. V08 is asymptomatic HIV. This code is also used to report patients that are HIV positive or HIV positive status. V65.44 is the code for HIV counseling. 042 is the code for HIV disease or HIV infection. This code is also used for to report AIDS, AIDS-like syndrome, AIDS-related complex, symptomatic HIV infection, and HIV-1. For those patients who are diagnosed with HIV-1 and HIV-2, it is necessary to report, in addition to diagnosis code 042, you have to report diagnosis code 07953 for the HIV-2 condition. So these two codes go hand in hand whenever a patient is diagnosed with HIV-1 and HIV-2. The HIV-2 diagnosis code is only reported as the secondary diagnosis. The principal diagnosis in this case should always be 042. The last commonly used diagnosis code is 795.71, nonspecific evidence of HIV. This code is also reported for, this code is also used to reflect an inconclusive HIV test. Some additional information regarding the inconclusive HIV test. When newborn babies are born to HIV-positive mothers, they often have a diagnosis of HIV positive as a result of the mother's antibody status. The diagnosis of HIV positive in a newborn could typically last up to 18 months after, without the newborn ever becoming infected with the HIV or AIDS virus. This is known as a false positive result. Another term for false positive in this case is inconclusive HIV testing. Test results. And the diagnosis code for an inconclusive test result is 795.71. Some additional information about HIV and AIDS care is opportunistic infection. People with healthy immune systems can be exposed to certain viruses, bacteria, or parasites and have no reaction to them. Oftentimes, people living with HIV and AIDS face serious health threats known as opportunistic infections. HIV and AIDS-related opportunistic infections take advantage of the weakened immune system and oftentimes result in life-threatening illnesses. The most severe opportunistic infections occur when the CD4 count is below 200 cells, and oftentimes patients with HIV and AIDS commonly have opportunistic infections that lead to death in most cases. So it's important to know how to assign the appropriate diagnosis code so that you can appropriately treat the patients that have AIDS and any of those opportunistic infections that are out there. If you visit the CDC's webpage, they provide you with a comprehensive list of the common opportunistic infections. Here's just a short list. You have candidiasis, also known as thrush, cytomegalovirus, CMV, herpes simplex virus, chronic, Kaposi sarcoma, Mycobacterium avium complex, MAC or MAI, pneumocystis pneumonia, PCP, toxoplasmosis, toxo, tuberculosis, recurrent severe bacterial pneumonia, wasting syndrome, and malaria. So this is just a short list of the most common opportunistic infections, but if you want the complete list, you can visit the CDC's webpage. So let's look at the first coding example. And again, let's remember that these examples are specific to the diagnosis code only. So this is a 27-year-old patient that presents to the primary care physician's office concerned about recently having unprotected sex and requests an HIV test. The physician performs a well visit after reviewing the chart and notating that the patient hasn't had one in a year. The physician spends some time counseling the patient and also performs a rapid HIV test. So for the purposes of this scenario, this is a well visit diagnosis, B70, and this diagnosis should be listed as the principal diagnosis because this reflects the comprehensive care that was provided to the patient. So although the patient presented for an HIV pretest, the physician also made the decision to perform preventive care. So the preventive care diagnosis code should be listed as the principal diagnosis. The HIV screening diagnosis should be listed as the secondary diagnosis, V73.89. The physician counseled the patient, and the counseling code is V65.44. This was an optional code. It's not mandatory, but because the physician documents in the chart that the patient had unprotected sex, the decision was made to also include a diagnosis of high-risk sexual behavior, V69.2. So let's look at the rationale for this case study. This is a general medical exam, a well visit. So the principal diagnosis we noted was the well visit diagnosis. The HIV special screen diagnosis, V7389, was secondary. The physician counseled the patient, V65.44. And lastly, because the chart mentions the patient had unprotected sex, V69.2 was also listed as the diagnosis. Let's look at another case study. This is a case study that focuses on a chart that reflects HIV post-test counseling where the test results are negative. The patient returns for their test results. The physician advises the patient that they are negative and that the test results are negative, and counsels the patient for 30 minutes on the importance of safe sex and contraceptive methods. The physician distributes some contraception and advises the patient to return in 3 months for a test retake. The negative test result warrants a counseling diagnosis of V65.44. The doctor also made the decision to utilize high-risk sex behavior as a secondary diagnosis. And the bottom of the slide basically provides you the rationale for the two diagnoses. The patient returned for their results, so the physician counseled the patient and also provided some contraceptive methods. So V65.44 is the principal diagnosis, and high-risk sex behavior, V69.2, is the secondary diagnosis. The next example reflects HIV post-test counseling where the test results are positive, asymptomatic. The patient returns for their test results, and the physician advises the patient that they are HIV positive. The physician counsels the patient and explains what it means to have a diagnosis of HIV positive versus the HIV infection. The physician also counsels the patient on the proper use of medication, implements a treatment plan, discusses the treatment plan with the patient, and advises the patient to return in 3 months for a retest. Since the patient has a test result of HIV positive, the appropriate code would be the diagnosis for asymptomatic HIV or HIV positive, V08. The physician also counseled the patient, so the secondary diagnosis is V65.44. Although the code V69.2 is not listed here, it's up to the provider's discretion whether or not you want to use V69.2 as the third diagnosis. If the decision to only use the two diagnoses that are listed here, V08 and V65.44, it's appropriate, but you could make the argument that it is appropriate also to utilize V69.2 since the patient had unprotected sex. So here's the rationale for the code selection for a patient whose test results are positive asymptomatic. So we indicated that V08 is HIV positive and V65.44 is for the counseling aspect. The next example provides an overview of HIV post-test counseling for positive results where the patient is symptomatic. The patient returns for their test results and the physician advises the patient that they have the HIV infection. The physician counsels the patient and explains in detail what HIV infection is. A treatment plan is implemented and discussed. The importance of taking medication is discussed. And the importance of practicing safe sex at all times is also discussed. In this instance, because the patient has been diagnosed with the HIV infection, 042 is the principal diagnosis. The physician also counseled the patient on proper, the importance of taking medication and the importance of practicing safe sex. And in this instance, the secondary diagnosis of V65.44 is also assigned. An additional code, not mandatory, is V69.2 for high-risk behavior. So again, the coding scenario is considered correct as is, but you could also assign V69.2 based on the documentation that the patient is high-risk sex behavior. And so here again is the rationale for this scenario where the patient is diagnosed with the HIV infection. So the principal diagnosis is 042, and the secondary diagnosis is V65.44. The next example is HIV post-test counseling, positive results, where the patient is diagnosed with HIV-1 and HIV-2. So again, the physician counsels the patient and explains in detail what the HIV infection 1 and 2 is. A treatment plan is discussed and implemented. The importance of taking medication is discussed. The importance of practicing safe sex is also discussed. And the diagnoses in this case is HIV infection, principal diagnosis 042, HIV-2 infection 079.53, the counseling code V65.44, and an optional code V69.2. So again, in this instance, it's not mandatory, but if the physician feels that the patient's behavior is high risk, then it is acceptable to also code V69.2. So here's the rationale for the patient who has been diagnosed with HIV-1 and HIV-2. So the principal diagnosis is 042. Secondary diagnosis is 079.53. V65.44 is the third code. So now just some important points about coding and sequencing the correct codes. The coding guidelines dictate the importance of sequencing 079.53 as the secondary diagnosis. 079.53 would never be reported as the principal diagnosis, and it would never be reported as, the 079.53 is only reported as a secondary diagnosis, and it would never be reported alone. The next example is HIV counseling without testing. A 17-year-old patient presents to her GYN to discuss contraceptive options and safe sex. The physician counsels the patient on various methods and suggests an HIV test. And initially, the patient agreed to take the HIV screening, but then later declined. The attending physician spends 45 minutes counseling the patient and asks the patient to reconsider the HIV test at a later date. In this instance, the only diagnosis code that is needed for this scenario is HIV counseling, V65.44. And the rationale for this example is here at the bottom of the slide. Patient presents for counseling, HIV counseling, V65.44. Case study number 7, antiretroviral therapy visit for a newborn. An HIV-positive mom brings her 2-month-old baby to the pediatrician's office for antiretroviral therapy follow-up. The physician documents an expanded problem-focused history and performs a brief exam. Upon review of the lab results, the physician makes the decision to modify the medication. A revised treatment plan is discussed, and the physician advises the patient to return in 1 month. Since the newborn baby has a test result of HIV positive because of the mom's status, the diagnosis of inconclusive HIV test should be reported, 795.71. The secondary diagnosis for this scenario is pre-exposure prophylaxis, B01.79. So those are the only 2 codes that would be assigned to the scenario for a newborn baby. And this slide provides the rationale for the 2 codes that were selected for this newborn. The HIV positive diagnosis that is assigned to the newborn is actually not the newborn's diagnosis, but instead it's the mother's antibody status. And since we indicated in an earlier slide that a false positive diagnosis could last up to 18 months in a newborn, the rationale for 795.71 is this statement that speaks to the false positive results. Pre-exposure prophylactics, P01.79, is also a supplemental diagnosis code that reflects the newborn's diagnosis. So just a few coding tips to remember. According to the ICD-9 coding guidelines, the ICD-9 code 042 includes the following terms: acquired immune deficiency syndrome, acquired immunodeficiency syndrome, AIDS, AIDS-like syndrome, AIDS-related complex, HIV infection symptomatic, and HIV-1. So that's 042. For patients, for the purposes of treating patients that are presenting for HIV and AIDS care, this code should only be reported or confirmed cases of AIDS or HIV infection. Any documentation that states possible or probably, rule out or suspected or suspicion of are never reported as AIDS. You should defer to one of the other codes that we spoke about on the diagnosis. I'm sorry, let's go back here. On the diagnosis coding slide, which was, let's go back here again. Apologize. Okay, I can't. Okay, I believe it was 9, and I apologize while I try to locate slide number 9. No, it was 10. Here we go. So 042 is the confirmed diagnosis of the HIV infection. So for patients that are probable, contact your local Medicaid agency for specific guidance. But the 2 codes that you could possibly consider are exposure or pre-exposure, or if they've had a test and it's inconclusive, 795.71. So let's go back. All right. Next slide. Some additional coding tips. A diagnosis of HIV positive and asymptomatic HIV is not the same as a diagnosis of HIV infection. So it's important to note that when a patient has a confirmed diagnosis of HIV infection, this is the code that should always be reported on their chart. You should never go back to reporting asymptomatic HIV, the diagnosis B08, once a patient has a confirmed diagnosis of AIDS. Some patients may test positive, but may never become sick for many years. And so in those instances, the code B08 would be reported on these patients' charts. But once there's a confirmed diagnosis of HIV infection or AIDS, then you would begin to report this diagnosis on their chart. Symptomatic HIV and inconclusive HIV are never reported once the patient has a confirmed diagnosis. So once the documentation states that the patient has the confirmed HIV infection or AIDS, this is always going to be their chart, the diagnosis that's documented on the patient's medical record. So some additional coding tips. Actually, I need to go back one. An HIV positive diagnosis code would never be reported in addition to an HIV-related illness. So that would be your opportunistic infection codes. So if a patient has an opportunistic infection and they also have the HIV condition, you should be reporting diagnosis code 042 with the appropriate opportunistic infection code. Next slide, HIV-2 infection. So the diagnosis code 079.53 is for the HIV-2 infection. But this code is only reported in conjunction with diagnosis code 042, which is reported as the principal diagnosis. Some additional coding tips: inconclusive or non-specific HIV test results, diagnosis, the correct code to report is 795.71. Exposure to or pre-exposure to or contact with someone who has HIV or AIDS, V01.79. And it's important to note that this code is reported as the principal, as the secondary diagnosis, never as the principal diagnosis. Patients that engage in unsafe sex practices or behavior that increases their risk of getting HIV or AIDS, you assign the diagnosis code V69.8. And anywhere in the presentation or the slide where you see the asterisks, it's important to note that the code that has the asterisks means that the code is reported as the secondary diagnosis and that it would never be reported as the principal diagnosis. And this note here is at the bottom of the slide for reference. For patients that come in for a well visit or annual exam, the principal diagnosis is always going to be V70.0. In addition, if they get HIV testing and counseling, the secondary diagnosis is V65.44. Patients that come in for testing and counseling, it's V73.89 and V65.44. And I need to just go back and correct something. This bullet here says includes testing and counseling. In this example, it's just counseling, not testing. So if a patient presents for well visit and they also have HIV counseling, the code is V70.0 and V65.44. If the patient comes in for HIV testing and counseling, it's V73.89 and V65.44. If the patient comes in for a well visit, HIV testing and counseling, it's V70.0, V73.89, and the last code is V65.44. So in the third example that I just made up, there would be three codes, V70.0, V73.89, and lastly, V65.44. Medical records that state that a patient also has any of the common opportunistic infections. It is important to note that the code for the HIV infection is always listed as the principal diagnosis, and any of the opportunistic infections codes should be reported as the secondary diagnosis. So here in this bullet, it just gives you some examples of opportunistic infections that are commonly inherent in the HIV infection. So it's pneumocystis carinii pneumonia, 136.3, and Kaposi sarcoma. The Kaposi sarcoma code has a series, so it could be 176.0, 176.1. So depending on what the code is, where you see the X placeholder would be canceled out with either 0 or 1 or whatever the appropriate digit for that code selection. Some additional coding tips that specifically speak about code sequencing, which we were actually just covering on the prior slide. When it is necessary to report multiple diagnosis codes, it is important to ensure accurate interpretation of the coding guidelines and ensure proper sequencing of any diagnosis codes. So in the examples that we were looking at in the previous slide, coding guidelines denote that a principal diagnosis versus a secondary diagnosis must be adhered to. So for example, the HIV-2 code is a secondary diagnosis code only. So this code would never be sequenced as a principal. The HIV-1 code is always sequenced as a principal diagnosis. And in the case of HIV-1 and 2 on the same encounter or in the chart documentation, this code would never be reported as a secondary. Some additional coding tips regarding sequencing. All of the opportunistic infection codes are always sequenced as the secondary diagnosis. The HIV-2 code is always assigned as a secondary diagnosis when documented. And so the last three slides, beginning with the web resources, are additional supplemental resources that can be queried should you have any questions regarding the ICD-9 codes that were discussed in this series. Additionally, you should contact your local Medicaid state agency for further guidance.